Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm joined by our deputy editor, Nick Bostock, to talk about some of the latest news affecting general practice. Coming up, we're talking about the BMA Special Representative meeting that happened last weekend and what went on there, including what Health and Social Care Secretary Wes Streeting had to say, some of which enraged many of the GPs in attendance. We'll be discussing the rollout of neighbourhood health in England as the government announced the 43 sites that will form the first wave of its national programme to shift the NHS to this new way of working. And we're looking at a piece of work Nick has done over the past couple of weeks, looking at the number of GPs the NHS in England needs over the coming years if it's to keep pace with the predicted population rise, including which parts of the country have the furthest to go to reach the levels required. Later on, our senior reporter Kimberly Hackett will be joining me to talk about our good news story, which this week is about an initiative in Wales that's aiming to support women GPs into senior leadership roles. That's all to come on this episode of Talking General Practice. Before we start, just a quick message from our colleagues on MIMS Learning. In-person learning is a vital part of keeping up to date, enabling GPs and other health professionals to learn with colleagues, ask questions of expert speakers and benefit from networking. MIMS Learning's event page gives you details of all the general practice focused learning events, which will provide you with practical take-home points for your practice, along with CPD certification. Visit mimslearning.co.uk/pages/events to find out more. So Nick, the BMA held a special representative meeting on Sunday to debate the 10-year health plan and vote on a range of motions to decide the union's response to various elements of the plan. A special representative meeting is effectively an emergency meeting, isn't it? Wes Streeting spoke to doctors attending the event before the debates got underway. What exactly did he have to say generally about his plans?
Essentially, the speech Wes Streeting gave was an appeal for more time, as well as a sort of warning or maybe a threat even that if doctors don't work with this government, one that's much worse for them and the NHS as a whole will come along next. He acknowledged that many doctors aren't happy with the government. Resident doctors are in dispute. Consultants have indicated they would support a return to industrial action. GPs could soon be back in dispute with the government too. So there's plenty of evidence of how deep doctors' frustrations with the government run. And it's only been about 15 months since the last general election. But Wes Streeting said financial constraints mean there's only so far the government can go in terms of NHS funding and pay settlements for staff. And he said he needed more understanding from the profession, essentially, of those constraints and more time. He pointed to some of the things the government's done since taking office: pay awards for doctors, investment in the GP contract, GP jobs created through the additional roles reimbursement scheme. And he pointed to a fall in the NHS waiting list and rising satisfaction with GP services too. So his argument was the government is trying to move things in the right direction in tough circumstances and that there is some evidence it's working. And the message to doctors was he needs them to be partners, not adversaries. He also said that the NHS was hanging by a thread and that if doctors pulled on that thread by opposing the government's 10-year health plan or taking industrial action, it would break and the NHS could be lost. So it's essentially give us more time, work with the government or else. We're going to come on to what happened during the rest of the conference and what doctors had to say about the government's plans. But persuading doctors to get on board as partners in the government's reform plans may be difficult, perhaps in part because that sense of partnership Wes Streeting says he wants seems to have been lacking in drawing up the plans. Wes Streeting said in his speech that the 10-year plan had been co-designed with the BMA Brains Trust. There was obviously a consultation process as the plan was being developed, but it definitely wasn't co-written with the profession's leaders. And for example, although it had lots to say about general practice, GP leaders said they hadn't seen it before it was published. And they say that the proposals actually threaten the future of general practice. So like I said, this was an appeal for the medical profession to work with the government. And I think inevitably part of the calculation for Wes Streeting is that if the rest of this parliament is marked by industrial action from doctors, it's not just the NHS, but the government too that'll be hanging by a thread.
The bit we focused on in terms of what we covered on the website that is probably of real interest to listeners is obviously what he said about general practice. In particular, he had some very unpopular things to say about online access, didn't he? What did he actually say?
This came up in the Q&A after the main speech. And again, I think if the government is trying to say it wants to work with the medical profession, this is precisely the kind of thing that seems to scream the diametric opposite. From the 1st of October, GP practices will be contractually required to keep their online consultation systems open throughout core hours. So that's Monday to Friday from 8 a.m. to 6:30 p.m. And this was a change that was announced back in April, but it was postponed to halfway through the financial year to give practices a bit more time. Many GPs are really worried that being forced to keep these systems on all day rather than being able to switch them off when they've hit capacity in terms of the numbers of messages they can feasibly handle means another source of unlimited workload that could ultimately put patient safety at risk. So during the Q&A, Wes Streeting was told that GPs had only agreed to this change to their contract on the basis that some safeguards would be agreed before it took effect. These safeguards haven't materialised, so he was asked if he would work with GPs to help avoid a possible return to industrial action. A response started okay. Mr. Streeting said the government wanted to do everything we can to support practices in terms of the change to online access from the 1st of October. But then, instead of acknowledging any concerns practices might have, he accused practices that weren't enthusiastic about the change of being naive and of having decided that they just couldn't be bothered to make the change in many cases. And he said, in any kind of reform or change programme, you'll have your leaders and your laggards. And he said the laggards need to get with the 21st century. He also mentioned working with NHS England to identify practices that were struggling to meet the deadline. But given the comments about laggards and so on, those practices might now be quite worried about whether any concerns they have will be taken at face value, I would think.
It's safe to say a lot of the GPs attending the conference didn't really react very well to this, did they?
No, they didn't. Some GPs just said the remarks from the Health and Social Care Secretary were flat out offensive. But there were also some contributions explaining why practices are concerned about the impact this change is likely to have on workload and safety. One GP said that although online consultation systems are only meant to be used for non-urgent issues, unlimited numbers of queries coming through this system, if they're on all day throughout core hours, would all have to be screened to make sure that something urgent hasn't slipped in. And he said practices need to be able to stop when they reach the limit of what they can manage each day. But this new contract requirement has basically sort of thrown that notion out the window. Another GP said the change was dangerous, unsustainable and unfair. And then the conference actually, as a whole, backed a motion warning that unlimited patient online demand will jeopardise and lead to burnout for all medical staff, not just GPs. So there's a lot of serious concern. And the response from the Health and Social Care Secretary ultimately just seemed a bit too dismissive of that.
It isn't just GPs who are worried about this either, is it? Last week, I wrote a story about a statement put out by the Institute of General Practice Management about this. I mean, the IGPM have called on NHS England to provide dedicated and recurrent funding to cover the work involved with all of this. Basically, they're saying that this requirement for online access to be open all day, coupled with the new GP patient charter, which says that patients will be told what will happen to their query on that day, means that this is basically introducing active triage or total triage to general practice as a contractual requirement, really, without the funding and resources to support practices to do it safely. NHS England confirmed to you, Nick, didn't they, that automated messages or blanket diverts to other services without active triage would not cover what's expected of practices as part of the new contract requirements, as part of this new GP patient charter. And the IGPM is basically saying this raises really serious risks and questions about patient safety. And they've basically called for this to be paused until there are guarantees it can be introduced safely. From their point of view, they were pointing out that a big chunk of this work is also going to fall on practice managers, as they're basically going to have to be responsible for redesigning systems and the way contact to the practice operates. I think the IGPM also made a really valid point in all of this is that it basically ignores practices that have actively looked at this and chosen not to use that triage model, and they are managing access and demand in a way that suits their practice and that their patients like. So, there's that to consider as part of this as well.
Yeah, so it feels like a sort of top-down change being imposed. Online consultations, though, weren't the only thing that were sort of worrying people at the conference, were they? I mean, you watched a lot of the debates throughout the day. How would you sum up what was going on and the sorts of things doctors were supporting?
All of the issues that were kind of up for debate were obviously the things that are most contentious about the 10-year plan from the point of view of doctors. The debates and then the votes from the BMA representative body, as I mentioned earlier, they're basically there to inform the BMA's position on what it should be on all these issues. So they've got a clear steer on what they should be lobbying for and what they should be pushing for in any negotiations with the government. So they were never going to be discussing the things in the plan that are uncontroversial. It was always going to be about the most controversial aspects of the plan. But I think it is fair to say that there are a lot of things that the BMA are concerned about. And really, chief of them, I think, is the impact all of this will have on general practice. There were 19 motions in total up for debate, and 6 of them were mainly about general practice, or totally about general practice. I'll perhaps cover off some of the other issues that I thought were interesting that came up a bit later, but perhaps let's focus on general practice first. Perhaps the thing that was most striking, and one of the things that we put in the top of our story about this, was that the meeting voted to condemn and oppose the 10-year plan as it is currently written, which was part of a motion in a debate about general practice. But the meeting actually backed every motion relating to general practice, which included another one saying the 10-year plan should be opposed if the independent contractor status of GPs is not safeguarded. So they basically voted to oppose the 10-year plan twice. BMA representatives also voted that the BMA should support GPs to re-enter industrial dispute with the government unless safeguards were introduced to protect the partnership model. They backed a call for no GP contracts beyond those already run by foundation trusts to be transferred to hospitals. And they also voted in favour of the BMA campaigning against the introduction of integrated health organisations and basically opposing those every step of the way. And they also supported a motion instructing the GP committee to make universal use of the union's template contract, model contract for salaried GPs, a red line in any negotiations on the future of general practice. That motion was really warning that the 10-year plan risked accelerating a shift away from partnership towards a salaried service. And so it was essential that GPs have protections on terms and conditions, regardless of who they're working for. But I think one of the things that did come through is something you mentioned earlier, Nick. There was a real sense of anger that the BMA weren't consulted about any of the 10-year plan before it was published. A few of the speakers were really very unhappy about that. This idea of shifting care out of hospitals into the community, as well as bringing back the family doctor, key election pledges, they're pretty reliant on GPs. So you'd think you'd want to make sure that they were signed up to the plan that's going to deliver this. But as you say, the plan proposing how to do all this, doctors do see it as a major threat to the current way they deliver care in general practice. You were talking about the reaction to Wes Streeting's comments earlier. One thing that really stood out to me was a GP basically said that after hearing his speech, she'd come to the conclusion that the government had no idea how important the GMS contract was to the delivery of safe and effective and cost-effective general practice. She said she'd been quite wary of re-entering dispute, but that the BMA needed to back GPs to have that option after she'd heard what Wes Streeting had to say. So I think that says a lot. And there were a lot of comments from GPs really concerned about this direction of travel, about the future of GP partnerships, worries that the profession is heading towards a salaried service, that the changes the government is proposing will undermine practices. For example, if funding for things like local enhanced services gets pooled into neighbourhood budgets, that could potentially leave practices financially unviable. I think we've mentioned that on the podcast before. I mentioned at the very start, Nick, that the BMA GP committee is meeting as we record this on Thursday for what's set to be a really crucial meeting. They are potentially due to vote on whether to send the profession back into industrial dispute at this meeting, aren't they?
Just to recap, the BMA gave the government from its last GP meeting in July until today, so about 2 months, to deliver on a list of demands. We talked about this on the last news podcast, but to sort of run through it again, the BMA GP committee wants the government to confirm the funding envelope for next year's GP contract, so basically the amount of money available for a funding uplift and any services it wants to fund as part of that contract package. as well as the funding envelope for the major new contract that it wants to negotiate by the end of the current Parliament. They also want a roadmap setting out plans to reverse erosion of practice funding. They want additional roles reimbursement scheme, ARS money moved into a practice level scheme. They want a scheme to tackle GP unemployment, and they want some guarantees around indemnity and GP's role in neighbourhoods. And just coming back to what we talked about earlier, the GP committee also wants safeguards around the change to online access. And all of these things, as far as we know, have just not materialised. So given the mood at the special representative meeting and the fact that there doesn't seem to have been much movement on any of these demands, it looks like there's every chance that as we speak, GPs could be looking at a return to industrial dispute.
I think I wrote an opinion piece before the BMA meeting that said Wes Streeting had a real opportunity to come to that meeting and potentially address some of the concerns the GP committee had. And instead, that laggard comment and dismissing these concerns about online access has basically seemed to inflame the situation, maybe rather than calm it down. So obviously we'll have to wait and see what comes out of that meeting today. So and obviously we'll be keeping track of that on GP Online. I mentioned earlier that it's not just general practice that's a big issue or big problem from the 10-year plan. There were also debates about at that meeting about education, about expanding the number of specialty training places, which the BMA is arguing don't go far enough. But two things I thought were interesting were the debates about AI and genomics. I think when we spoke about the 10-year plan on the podcast, we mentioned these 5 big bets the government was going to go big on to help deliver improvements in patient care and productivity, which are data, AI, genomics, wearables, and robotics in surgery. And the BMA meeting suggests that doctors have some real problems with the first 3 of those. A lot of the concern about data and data security around the plans for a single patient record, who's going to have access to that, who will be running that system, and what all that means. You know, there's a real lack of detail, as with most things in the plan, about what that means in reality. So I think the BMA will be pushing very, very hard for tight safeguards on what happens to patient data. AI is much the same. Some doctors are clearly worried about what this new technology means for patient data and how that patient data is being used. Some concerns about over-reliance on technology that's potentially biased and prone to hallucinations and what all that could mean. You know, there's no doubt there's massive benefits to be had from this new technology. But again, it really is about how it's going to be introduced. That's key. And I think as things develop, the BMA looks likely to be very, very cautious about how AI is deployed. And I'm sure they'll be very vocal about raising objections to plans they don't believe are helpful. And the genomics plans are also causing a lot of issues. You can see from policymakers' point of view, this idea of using genomics and gene sequencing to help predict a person's risk of disease all seems like a great idea and could help with prevention and targeting medicines. You know, like AI, it could unlock huge potential breakthroughs in terms of medicine as well. But there are all sorts of ethical and practical issues about how you roll this out. And again, there's no detail on what it means in practice when the government says it's going to invest in genomics. You know, what will that look like for the average person? What will that mean for the NHS and general practice? So, for example, what happens if someone is identified at a very high risk of dying at 50? You know, how secure is that information going to be? Would it be disclosed to insurers? If someone is identified as having a gene that means they will develop a serious condition, that has implications for them and all of their family members. So where do GPs send these people? Genetic counselling services can't meet the current demand, let alone the new demand these plans would unearth. So I think some of these issues around data, genomics and AI, they're potentially really thorny and problematic, and not just for doctors, but also the public more generally when they understand what they might mean. And I think they could throw up some real challenges for the government as they start to make some of these ideas a reality.
The other thing that also happened in the week leading up to the conference is that the government announced the 43 sites that will inform the first wave of the National Neighbourhood Health Implementation Programme. So these are the sites that will be the first to roll out this new approach to neighbourhood health. What do we know about them?
Yeah, last week the government announced that 43 sites have been chosen as this first wave of the programme. We talked about this programme on the podcast before when it was first announced. If people remember, NHS England was really clear at the time that this is not a pilot. Basically, these sites are going to be taking a test and learn approach to work out how they can develop neighbourhood health in their area. And then these sites are expected to be exemplars for other local areas. So this isn't a pilot. Basically, neighbourhood health is supposed to be being rolled out across the country. It's just these 43 sites are going to get a bit more intervention and a bit more help to do it. And then they will be able to pass on their learning to their fellow neighbourhoods in their local area. Wes Streeting said that these 43 sites will initially focus on vulnerable people with multiple long-term conditions, and then the aim will be to provide more joined-up care for this group and more care closer to home, and then they will move on to other patient groups as time goes on. He also said, and this is quite crucial, these 43 sites will act as test beds for the new primary care contracts and funding flows that are mentioned in the 10-year plan. So these are those neighbourhood and multi-neighbourhood contracts that we've talked about before. They've been billed as alternatives to the GP partnership, and the first of these could be up and running as early as next year. The 43 sites are not in every ICB area at the minute, but NHS England said they would cover every ICB, basically once all the reconfiguration has happened. Wes Streeting did say that GPs would be the cornerstones of neighbourhood health, but no extra explanation on what that means. In terms of what they get for being part of the programme, they each get a national coach to help them accelerate developing neighbourhood health, and also some learning groups and things so they can learn from each other. But as we talked about on the podcast before, there is no new funding to do this. They've got to do this all out of their existing pot of money. So I think all eyes are going to be on these 43 sites to see how they get on. And in particular, I think GPs will be interested to see what sort of appetite there is from practices and PCNs in these areas for taking on those new contracts, and whether GPs working in these 43 sites believe there's any benefits in making that move and feel the future of their practice will still be protected if they're working in these new contractual arrangements. So we'll definitely, obviously, be following how they get on. Moving on, Nick, last week you were looking at predicted population growth in England and what this means for the number of GPs we need. What did you find?
I came across some figures from the Office for National Statistics that predicted population growth over the next 20 years or so. And I thought I'd look at what that meant for the number of GPs England will need over the next decade and a half. In terms of where we are now, the average fully qualified full-time equivalent GP in England is responsible for around 2,260 patients. And that national average figure has actually come down by about 40 patients per GP over the past couple of years. But it's still way above the 1,800 patients per GP ratio that GP leaders have often quoted as a safe limit. By 2040, so that's why I talked about looking at what it means for GP numbers over the next decade and a half. By 2040, the BMA wants the NHS to move to what it calls a gold standard of 1,000 patients per GP. So that's less than half the level we're at now. But obviously, the population isn't going to stand still over the next 15 years. There could be around 68 million patients registered with GPs by 2040. That's up from just over 63.5 million now. We currently have 28,278 fully qualified full-time equivalent GPs in England. And once you factor in projected population growth, that would need to rise to nearly 37,800 by 2040 to get to 1,800 patients per GP. And we'd need just over 68,000 GPs to get to that gold standard level of 1,000 patients per GP. So to put it another way, to get to that gold standard level the BMA wants, the GP workforce needs to grow to about 2.4 times its current size over the next 15 years. The BMA wants to see England move towards that gold standard ratio because it says that's what general practice needs to improve continuity of care for patients, to make care safer, and workloads manageable for doctors. And the ONS population stats give a real insight into why that shift is needed too. Over the next 15 years, the data show the population of England overall will rise by about 7%, but numbers of older people who are far more likely to have multiple chronic conditions, to need more consultations with GPs, far more likely to be complex patients to manage, are expected to rise a lot quicker than the population as a whole. So over 75s are projected to increase by 33% by 2040. So about 4 times the general population increase. And that's a big factor in why we need more GPs to bring down that ratio of patients per GP.
That's a really good point, that, isn't it? I mean, the ageing population is a big factor in all of this. You had a look at the regional breakdown as well. And as with everything, not all areas are equal, are they? What did you find?
We know already that there's big variation in the number of patients per full-time GP across the country. The national average is around 2,260, as I said. But some ICB areas have nearly 3,000 patients per GP and others fewer than 2,000. So areas with the highest numbers of patients per GP currently, like Bedfordshire, Luton and Milton Keynes ICB, North West London, Kent and Medway, those areas need a lot more GPs because they currently have the greatest shortfalls. 2 of those areas also have above average projected population growth over the next 15 years. So their task is doubly difficult in terms of achieving a safe balance between patients and GPs over that period. But what our analysis shows too is that in some areas that are currently closest to safe levels of patients per GP, in some cases, they face 10% plus population increases over the coming years. So they're also going to be under pressure when it comes to maintaining a safe balance.
The BMA and RCGP have been calling for more GPs for many, many years. What did they have to say about all of this?
The BMA said these figures make clear that the government needs to make a genuine long-term commitment to fixing the GP workforce crisis, expanding training places, doing more to retain GPs and intervening to tackle the problem we have at the moment with thousands of GPs being unemployed or underemployed because practices can't afford to recruit. And that's something the BMA said would need to happen in part through talks on the major new contract that it hopes to negotiate within this Parliament for general practice. The RCGP said patients per GP had been climbing steadily for decades and becoming more and more unsafe and unmanageable. I mentioned those figures on rising numbers of older patients, and the college also made the point that rising complexity as well as overall numbers of patients mean that, GPs are struggling to keep up. And both the RCGP and BMA talked about the upcoming revamp of the NHS workforce plan, which the government has promised soon. They both suggested that a lot rests on what that offers, not only on training more GPs, but also on how the NHS can retain them.
We're talking about the workforce. You also wrote a pretty shocking story this week that suggests boosting the workforce is going to be a real challenge because so many GPs are leaving.
This was from a piece of research published in the BMJ. Researchers looked at the number of licensed GPs on the GMC register and compared that with numbers in NHS data on the GP workforce and numbers on the performers list. What they found was that 1 in 3 GPs with a licence to practice in England are not working in NHS general practice. It's a finding that really reflects the scale of the mismatch between numbers of GPs coming through training and numbers actually entering the NHS general practice workforce. And that mismatch is actually growing fairly fast. The researchers found that in 2015, about 1 in 4 licensed GPs were not working in the NHS, but that now it's gone up to 1 in 3. When you look at full-time equivalent figures, the gap is even bigger. Looking at it that way suggests that just over half of GMC registered GPs aren't working in the NHS. And what that means is that a cohort of GPs that it costs something like £13 billion to train have effectively been lost to the health service. One of the really shocking lines, I thought, was that the study said most newly qualified GPs never enter the NHS GP workforce or leave within the first 10 years. And it explores some of the potential factors: GP practices not being able to afford to recruit, international medical graduates who make up a substantial proportion of newly qualified GPs struggling to obtain visas, GPs working in non-NHS roles. But ultimately, this is more evidence that in addition to training more GPs, the NHS, the government, needs to work a lot harder to keep them.
Yeah, definitely. You mentioned the workforce plan and the RCGP and the BMA saying that's going to be quite crucial. And obviously, what the government is going to do about retention needs to be a really big factor. in that plan. And what other thing that happened over the last couple of weeks is that the BMA and RCGP signed a joint letter with lots of other organisations calling for more involvement in the government's development of that new workforce plan. We're expecting this new plan at some point in the autumn, but this letter suggests that there may currently be a real lack of engagement with key stakeholders over it. And that maybe echoes some of the concerns that doctors were raising at the BMA conference about this lack of discussion with the medical profession on the 10-year plan. Do you think this is something we should be worried about?
It absolutely echoes that point we discussed earlier. The government says it wants to work with the profession, but it doesn't seem that great at actually doing it. The revamped NHS workforce plan was meant to be out by the end of summer. Summer is now over. And we have this letter from 74 healthcare organisations, including the BMA and RCGP, saying they haven't been properly consulted. Presumably, we're currently at the end of the process in terms of developing that workforce plan, if it was supposed to be out towards the end of summer. If that consultation with those organisations was going to happen, it would have happened by now, you'd think. And that doesn't bode well for the workforce plan in terms of its chances of delivering what healthcare organisations think is needed. The 10-year health plan has already provoked concerns among health professionals, and a false step with the workforce plan really alienating a lot of NHS staff very early in this government's sort of time in office.
Yeah, definitely. That plan is going to be so crucial, what it actually says and how it intends to expand the workforce, particularly, the GP workforce and primary care. It's perhaps also worth mentioning that the BMA and RCGP have again raised the issue of international medical graduates, newly qualified GPs struggling to find jobs and having real issues with their visas. I mean, you touched on that earlier in that when you were talking about that study you wrote about this week. We haven't talked about this for a while on the podcast, but it is an issue that's not gone away, isn't it? Both the RCGP and the BMA wrote to the new Home Secretary last week to highlight the issue. The
BMA and RCGP wrote to the Health and Social Care Secretary, and their letters were underpinned by polling that they'd carried out among international medical graduate GP registrars. Because GP training lasts 3 years and you need to have been in the UK for 5 years to qualify for indefinite leave to remain, many newly qualified GPs who are international medical graduates, which generally means that they're from another country originally, need a visa to work in the UK for a couple of years after they complete GP training. 7 out of 10 of the registrars polled by the BMA and RCGP said finding a job with visa sponsorship was difficult or very difficult. And among registrars who are close to finishing their training within 4 months of finishing, that rose to 82%. And many of them said they may have to leave the UK to find work if nothing changes. So roughly half of doctors entering GP training at the moment are international medical graduates. So failing to solve this issue means that huge proportion of doctors coming through UK GP training face a really big barrier to ever actually joining the NHS GP workforce. And GP leaders say it wouldn't be hard to fix. Either the government offers doctors who complete training in the UK automatic leave to remain, or it could set up umbrella sponsor NHS organisations that could act as visa sponsors for large numbers of UK-trained GPs who need visas to work here at the start of their careers.
Before we go, we've just got time for our good news story, and I'm joined by our senior news reporter, Kimberly Hackett. So, Kimberly, this week's story is about a new leadership scheme in Wales. What's that all about?
Yes, so a programme has been set up in Wales to grow leadership talent in women GP registrars from underrepresented backgrounds. It's called Tyfu, which means growth in Welsh. And it was set up by Dr. Faye Stockton and Dr. Shalini Subu, who are both GP Associate Deans for Training at Health Education and Improvement Wales. Now, the idea came about after a 2022 BMA report was released called Delivering Racial Equality in Medicine. And it said that women from ethnic minorities in the UK face severe disadvantages in reaching senior positions in the NHS. So Dr. Stockton and Dr. Subu decided to do something to change that narrative in the GP world, and they set this programme up to help women build their confidence at work. So it's a year-long programme. 15 women are part of the first cohort, some of whom are international medical graduates, and others are British, but all are from ethnic minorities. And everyone who started was a GP registrar at the time, but a few have since CCT'd, but they are still on the course until it finishes. It's been 7 months since the programme launched, and there has already been a difference made. While there isn't any data yet, there has been some really positive feedback from the cohort. Some have said they are now more likely to speak up in meetings and contribute, and some have said that they feel they can achieve anything that they aspire to since being part of the course. So far, the programme only runs in Wales and it's not funded, but they do want it to continue, and they hope it will be picked up by the other nations as well. And they are more than happy to speak with people who want to be part of the next cohort in Wales and help anyone who wants to set up something similar, and their contact details will be in the story.
Brilliant. That's a great story. It's really positive. Thanks, Kimberly. Well, that's it for this week. Thanks so much for listening, and thanks to Nick and Kimberly. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.